rheumatology in the 21st century uses current cellular, biochemical, and immunologic techniques to explain the etiology of rheumatic diseases. While it is unlikely that molecular biology will differentiate rheumatic diseases into subsets based on their etiology, the genome revolution does provide us with new diagnostic tools, which are already beginning to have an impact. So when you compare the weight of drugs, so aspirin like a bicycle, insulin like a car, and monoclonal antibodies which we use to treat, for example, rheumatoid arthritis like an aeroplane. For many years, polymorphisms in drug metabolizing enzyme have been associated with both reduced clinical response and adverse effect of treatment. Proteomic and genomics offer new opportunity to identify biomarkers that provide surrogates of disease activity and response to therapy. MicroRNAs are small, imperfectly paired, double-stranded RNAs expressed in all cells, regulating the expression of hundreds of genes by inhibiting the translation and promoting the degradation of messenger RNAs. MicroRNAs act as master regulators of how a cell responds to changes in its environment, including growth factor and environmental stressors. There have been substantial advances in the field of rheumatology of the past 20 years in the management of rheumatoid arthritis, spondyloarthritis, psoriatic arthritis, systemic lupus erythematosus, and vasculitis. Here you see of pathogenesis of rheumatic arthritis. It's very complicated, so we think that environmental factors like a pathogen, for example, maybe Porphyromonas gingivitis, smoking, and genetic predisposition, HLA-DR4, PTPN22, PAD14, etc., going to citrulination of proteins and production of anti-citrulline antibodies. Then there are some changes in innate immunity and antigen presenting by dendritic cell to T cell and then activation of T cell and B cell product antibody, for example, rheumatoid factor and anti-citrulinate antibodies. In rheumatoid arthritis, we observe a production of tumor necrosis factor, interleukin-1, interleukin-6, interleukin-17. In 2010, ACR and Euler introduced new classification criteria for rheumatoid arthritis. So there are 4 points is this criteria. Joint involvement, and you see 1 medium to large joints is no point, but 4 to 10 small points is 3 points. Involvement on more than 10 points, in that at least 1 small joint is 5 points. Serology. We observe if patient has negative rheumatoid factor and negative anti-citrulline antibodies, or low positive or high positive. And we give 0 point or 3 point. Acute phase reactance, we must measure CRP and ESR and observe duration of symptom, less than 6 weeks, 0 points, and more than 6 weeks, 1 point. When we have 6 points together, the diagnosis of rheumatoid arthritis is confirmed. Following the introduction of treatment recommendation for rheumatoid arthritis in 2013 by Euler, and the introduction of biological agents in the management of rheumatoid arthritis, there is a need to consider the selection of the most appropriate therapy for an individual patient and to review how and when to switch treatment in those patients who do not show an optimal response. On the 6th of November 2012, FDA approved inhibitor of kinases to rheumatoid arthritis treatment. So we Euler divided treatment of rheumatoid arthritis to 3 phases. In the phase 1, we must start methotrexate in combination with low-dose glucocorticosteroids, but in short time, and if a patient is inconvenient to methotrexate, we must start leflunomide and sulfasalazine alone or in combination. When we have very serious case, a patient failure of lack of efficacy and or toxicity, or in phase 2 we go to biologic. And in the phase 3, when we observe phase of lack for lack of efficacy and or toxicity in phase 2, we go to tofacitinib, the first inhibitor of kinases. So, inhibitors of tumor necrosis factor alpha are the standard therapy in serious cases in rheumatoid arthritis, psoriatic arthritis, and spondyloarthropathies. We have now 5 inhibitors of TNF. So, etanercept, infliximab, adalimumab, golimumab, and certolizumab pegol. Another, our choice to treat rheumatoid arthritis or juvenile arthritis is abatacept. It's a modulator of co-stimulation, and you see the second drug for treated rheumatoid arthritis and juvenile arthritis is tocilizumab. It's an inhibitor of interleukin-6 receptor. Rituximab now is also a standard therapy serious cases rheumatoid arthritis patient, GPA and MPA. It's a factor against protein CD20 on lymphocyte B. The genus kinase, the signal transducer and activator of transduction JAK-STAT pathway, is the signaling target of a multitude of cytokines, including interferon gamma, interleukin 2, interleukin 4, interleukin 6, interleukin 7, 10, 12, 15, all of which are thought to have biologically significant roles in rheumatoid synovial inflammation. So you see the pathway from cellular into nucleus, JAK-STAT, and we stop this pathway. So it's another picture, and introduction the new classification criteria of spondyloarthropathies allow us to quick introduce tumor necrosis factor inhibitor to treatment on spondylitis, ankylosing spondylitis. For patients with back pain for 3 months and ages before 45 years, when we see sacroiliitis on imaging and maybe only in magnetic resonance imaging, plus one spondyloarthropathies feature, or in patients with HLA-20 B27 plus 2 other spondyloarthropathy feature, diagnosis of axial spondyloarthritis is confirmed. So, what are these spondyloarthritis feature? It's arthritis, enthesitis, inflammatory back pain, dactylitis, uveitis, psoriasis, inflammatory bowel disease, good response to non-steroidal anti-inflammatory drugs, family history of spondyloarthritis, HLA B27 present and elevated C-reactive protein. Only one feature or two features are necessary to confirm diagnosis. For patients, I'm sorry for mistake because it must be peripheral spondyloarthritis. For patients with peripheral arthritis, which are usually asymmetric and involve lower limb, or enthesitis or dactylitis, we must have one of next HLA B27, genitourinary or gastrointestinal infection, psoriasis, inflammatory bowel disease, magnetic resonance imaging, sacroiliitis, or two of arthritis, enthesitis, dactylitis, inflammatory back pain, or family history on spondyloarthritis. So we must treat this patient with no steroidal anti-inflammatory drugs. We observe failure of lack of efficacy. We start with tumor necrosis factor inhibitor. Psoriatic arthritis is a chronic inflammatory disease associated with multiple and variable clinical features. So we observe pain, overall reduced quality of life, skin manifestation, psychosocial problems, fatigue and sleep disturbance, difficulty with walking, interference with personal life, and stiffness and decreased function. We observe 5 overlapping clinical patterns in psoriatic arthritis. So we observe symmetrical polyarthritis similar to rheumatoid arthritis and differentiate only absence of rheumatoid factor. So the next pattern are axial disease. So peripheral joint may or may not be involved in these cases. So it's similar to ankylosing spondylitis, asymmetrical mono or oligoarthritis, arthritis mutilans, and DIP joint involvement only. So classification criteria for psoriatic arthritis according Caspar, very easy. So only psoriasis or psoriatic nail dystrophy, a negative test for rheumatoid factor, dactylitis, radiological evidence of juxta-articular new bone formation. GAPPA recommendation for management of psoriatic arthritis is according to feature. So peripheral arthritis, we start with non-steroidal anti-inflammatory drugs next, methotrexate or another, cyclosporin A, sulfasalazine, leflunomide, or biologic. In very serious cases, skin and nail disease, initiate topical therapy, and then methotrexate and biologic. Axial disease, only non-steroidal anti-inflammatory drugs and biologic. Dactylitis, and enthesitis, non-steroidal anti-inflammatory drugs and biologics. Euler recommendation for the management of psoriatic arthritis. In phase 1, we start with non-steroidal anti-inflammatory drugs plus local glucocorticosteroid injection. Phase 2, we start with methotrexate or leflunomide or sulfasalazine or cyclosporin A. In phase 3, we go to the tumor necrosis factor inhibitor, and in phase 4, we change the biological treatment. Maybe we switch to second tumor necrosis factor blocking drug. But we have new opportunity to treat treatment of psoriatic arthritis. So we can start with IL-17 inhibitor, ixekizumab or ustekinumab, a fully human IgG monoclonal antibody that binds to the common P40 subunit shared by interleukin 12 or 23, or we may start with apremilast, a phosphodiesterase 4 inhibitor. Phosphodiesterase 4 inhibitor degrades AMP into AMP. Elevated intracellular CAMP down regulated the inflammatory responses through inhibition of the expression of inflammatory cytokines and increasing the expression of anti-inflammatory interleukin 10. Pathogenesis of SLE is very complicated, and we observe genetic susceptibility in this patient. So we observe gene variants promoting innate immune activation, or gene variant increasing self-antigen, or gene variant promoting adaptive immune response. We observe excessive production of antibody, like anti-nuclear antibody, antibody against DNA, against RNA, against Rho, against La, etc. So, treatment of SLE, we must start with hydroxychloroquine, but we must assess disease activity, and according to disease activity, we must start with glucocorticosteroid or immunosuppressive drugs like azathioprine, mycophenol, and mofetil, or either cyclophosphamide in pulses. Belimumab, a fully human monoclonal antibody that inhibits B lymphocyte stimulator BLyS, was approved for the treatment of SLE in 2011. There is also a number of other novel therapies in development. The clinical data for this agent and their impact on the management of lupus is an important topic. And vasculitis. Classification of vasculitis is according to blood vessel size. So we have large vessel vasculitis, medium-sided vessel vasculitis, and small vessel vasculitis. Large vessel vasculitis, it's giant cell arteritis. It is granulomatosis arteritis of the aorta and its major branches. Takayasu arteritis, granulomatosis, inflammation of the aorta and its major branches also, but the Takayasu is a disease of young women, and giant cell arteritis it is disease of old people. Medium sizes vessel vasculitis is polyarteritis nodosa. It's necrotic inflammation of medium sizes of small arteries. And Kawasaki disease, the disease of children, arteritis involving large, medium sized and small arteries. Coronary arteries is very important and associated with mucocutaneous lymph node syndrome. And small vessels vasculitis is granulomatosis with polyangiitis, the old name Wegener. Granulomatosis inflammation involving the respiratory tract and necrotizing vasculitis affecting small to medium-sized vessel, and we observe necrotizing glomerulonephritis. Allergic granulomatosis with polyangiitis, the old name Sturge-Strauss syndrome. Eosinophil-rich and granulomatosis inflammation involving the respiratory tract and necrotizing vasculitis affecting small to medium sizes vessel associated with asthma and blood eosinophilia, and microscopic polyangiitis, necrotizing vasculitis with few or no immune deposit affecting small vessel. And necrotizing glomerulonephritis and microscopic polyangiitis is very common. IgA vasculitis is the old name henoxaline purpura. Vasculitis with IgA dominant immune deposit affecting small vessel. So typically involves skin, gut, and glomeruli, and associated with arthralgia or arthritis, and essential cryoglobulinemic vasculitis, vasculitis with cryoglobulin immune deposit, affecting small vessel, skin and glomeruli are often involved, and cutaneous leukocytoclastic angiitis, isolated cutaneous leukocytoclastic angiitis without systemic vasculitis. So, biopsy finding in major vasculitis syndrome we see depend on the type of disease, fibronoid, polynuclear cell infiltration, or lymphocyte, monocyte, eosinophil, giant cell granuloma. It depends on disease. Rituximab has been found to be an alternative to cyclophosphamide in the treatment of vasculitis. The general consensus was that cyclophosphamide continues to have a role, while rituximab may be considered a valid option to cyclophosphamide for remission induction in newly diagnosed patients with severe ANCA-associated vasculitis. In 2011, the FDA approved rituximab in combination with glucocorticosteroids for the treatment of granulomatosis with polyangiitis, GPA, the old name Wegener, and microscopic polyangiitis, two forms of ANCA-associated vasculitis. Thank you for your attention.
Thank you so much. This talk is open for questions. I wanted to ask you, do you have any experience comparing for, we use the anti-TNF so much for a lot of the rheumatoid arthritis and psoriatic arthritis. Have you had any experience to compare? Because the data with the IL-17 blockers, if there's more efficacy or compared to TNFs,
What drugs?
the new anti-TNFs, the ones that are coming out.
Yes, we treat many patients.